Hello everybody. Hi, can you see me? So we're going to talk about some thoracic vertebral anatomy. Main one you have to really know, right, is spinous process. Pretty obvious, coming right out the posterior side. Remember, this is anterior, posterior, and you're going to be palpating spinous processes, transverse processes on both sides. What's unique about the thoracic vertebrae here is that there is a transverse costal articulation with the ribs, as well as a superior costal and inferior costal surface, where it articulates with both the rib just above and below. And again, so there's two areas where each thoracic vertebrae articulates with that rib. You also have to know that this is the superior articular surface, and there's an inferior one on the underside. We're kind of taking a bird's eye view here. This is known as the pedicle, all right? And just superior to the pedicle is the superior vertebral notch, okay? And then if we look at the vertebral foramen, this is where your spinal cord passes through. So very important to have this nice and open. If a patient comes in with a, let's say the disc, which sits in this vertebral body cavity fossa here, if that impinges on the spinal cord inside of that vertebral foramen, you get problems, right? You get pain, you get nerve deficits, paresthesias, radiculopathy, etc. But again, you have to know all of this anatomy for the bone. You have the vertebral body here, spinous process, transverse, the lamina here. If you hear laminectomy, that's when they take part of this out so that you can create some more space in here artificially. But it does create a, let's say, vulnerable structure in the bone if you take the lamina out. So it's a clinical calculation you have to make. All right, so let's get into the techniques for the lab. All right, we have my resident here, Hannah. Say hi, Hannah. So what we're going to do here is do our thoracic techniques. First, we'll have you lie prone. And of course, she knows to kick off her shoes, right? And then I can hold onto your glasses. Thank you. So I'll put it in my pocket. Ta-da. All right, so unilateral prone pressure, it's on page 104 in Nicholas. Okay, if you look at my hand placement here, I'm finding where the spinous processes are. You can come up close if you want to see here. So spinous processes, you don't want to go right on them because it's very uncomfortable. It's a really, pointy bone near the surface. You want to come just off of it, treating the contralateral vertebral paraspinal muscles here. So I have my hands here, and it's a unilateral prone pressure. In the book, that first picture, he's got one hand. We do not treat with one hand. We have two hands that we're going to treat with, right? If you're just treating with one hand, you're doing something wrong on all techniques, I would say. So use all the instruments at your disposal, right? So you have two hands. I'm actually going to lower the table just a little bit so I can get right above the patient here, because I'm going to use a lot of my gravity and body weight to carry through this technique. So we're palpating for a really tight area. I'd say she's more tight in the mid-thoracics, T7, 8, 9. So I am going to use both my hands and just do a soft kneading motion here. And you might feel some fascial creep happening. But again, this is a soft tissue technique, so we're doing a rhythmic motion. I'm putting in maybe 20 to 30 pounds of pressure. I'm not putting like 100 pounds of pressure into here. How's it feeling?
Good.
Good? Not excellent? No, I'm just kidding. It's feeling excellent, I know. And so we do this rhythmic kneading motion. I'm moving kind of up and down based on what tissues need it, and you can feel, all right, maybe you spend more time in the middle because she's more tight right in here, and maybe I just do a little bit of a hold just to loosen that up. So again, and for reassessment, we're feeling if it's still really hypertonic. There's asymmetry from the right and left side. We're checking the fascia here, and things seem to be loosening up. For the next technique on 105, this is the catwalk variation. So if you have a cat, you know exactly what I'm talking about here. You're alternating your hands, almost like you're kneading bread. Some people call it making muffins. Whatever you like, bread or muffins, I like both, doesn't matter. And we're going up and down the thoracic spine, okay? Just like so. All right, and that's it for that. Now the next technique here is going to be on page 106. So this is what we call prone pressure, counterpressure. Again, this is bilateral for this one. So remember the prior techniques, we were treating the opposite side. Now we're going to be treating both at the same time. And what you're doing is you're putting pressure in towards the table. My arms are relatively straight, and we're shifting our pressure like this. Now you can go this way too, or this way, But remember, if we're going this way, we're actually side bending her spine to the left. And if we go this way, we're side bending it to the right. You can even just see in the texture of her clothes, if I shift this way, the fibers of her shirt here, side bend left. So we do some kneading motion up and down. And then maybe I switch hands. And since it's soft tissue, it's just a rhythmic motion. You almost want to try to make the patient fall asleep. That's always a bonus. That just means they're relaxed, like so, okay? Next technique is going to be on page 108, and that is a bilateral thumb pressure. You can use your thumbs approaching from the inferior aspect here, and it's this circular kind of motion, but you do want to use enough pressure to blanch your fingernails. So you see how they're not blanched, now they're blanched. All right, now and you always ask the patient, hey, is that too much? No? Sometimes they're like, put all of your weight into it, use more pressure. But really, it's this rhythmic kneading motion. You can move up and down the spine like so. So I'm moving down, I'm moving straight up, and I'm on both sides of that spinous process here. If we approach from the superior, more cephalad, now we're using doctor terms, right? We're med students now. If I'm approaching from the top, I can have a seat, or I could stand, and I'm doing the same thing, just going top down. Maybe I find a spot that's really resistant here, and I just hang out for a little bit. This will get your thumb strength nice and increased, and I'm just going back up and back down. Okay, so that is our thumb technique, thumb pressure. That's on page 108. Two more techniques. 111, so if you want to lie on your right side facing the whiteboard for me, and this is our kind of mid-lower thoracic lateral recumbent. I'm going to have you scoot down caudad a little bit, give you a pillow, fake pillow. All right, and so scoot towards me. So you want the patient towards you so you're not having to lean too far over. You can actually drape their arm over yours, or in the book, they have the arm at the side of the patient. But this, I feel like, is a really good way to get your hands close to the spine. You're staying on the ipsilateral side. So the spinous process is here. I'm hooking my fingers into those paraspinal muscles, and I'm trying to open that up by side bending away. So she's kind of side bending to the right, technically. And I'm really trying to open it like this. So it's like a scooping. You're not, what I see a lot of students do is like this kind of, that doesn't work. You need to be strong in your hands and scoop, almost like you're trying to scoop some wet sand and create a hole. So I'm here, you doing all right? Yeah. And now we go back up. You can even swap hands like this and get higher, okay, into here. And now we're mid-scapula, which everyone has pain in the mid-scapula, like so. All right. Maybe I hold it, maybe I focus in on this area. All right, and then the last technique is page 142. So you can lie face down. This is actually a myofascial release technique. So fascia, right? Not quite as deep as the muscle, we're just under the skin, and you feel this fascial motion, and I'm trying to use my whole hand to capture as much tissue as possible. So we can test cephalad, caudad, right to left, or rotation. Okay, clockwise, counterclockwise. So if I feel here what her ease preference is, she has a bind here, ease here. So bind, ease going to the left, bind to the right. So bind, and then if we check rotation, she's got an ease going clockwise, bind going counterclockwise. If I want to treat direct with direct MFR, I'm going to go superior to the right and counterclockwise. Now that is direct because I'm stacking the barriers, and you can hold and follow that fascial motion. Might be very subtle. And we hold for at least 30 seconds plus until we feel a release. If I want to go indirect, I go down to the left and clockwise. That's what she prefers, but you can still treat this way. All right, and then again, I follow that motion and I wait for a release to happen. So this is, again, myofascial release, different than soft tissue. I'm not doing a rhythm, I'm not kneading, I'm capturing the fascia and moving it either direct or indirect. And then to reassess, we recheck those planes of motion. That's it. Go ahead.
Hi, I'm Dr. David Aben. I'm going to assist Dr. King in explaining fascial creep. There is a phrase, a term in Nicholas when they describe myofascial release talking about fascial creep. What that means is when you set the patient up and you're looking for the barriers, cephalad, superior or inferior, caudad, and you take the planes and you stack them one on top of the other, you are then putting the patient into direct, meaning going into the barrier, or indirect with the barrier, and waiting for the fascia to creep towards your hands and the body will release. Hence the term myofascial release. So under the muscles and the fascia, which are together, like saran wrap around your body, which is what fascia is, and you're waiting for the muscles underneath your fingers, with that conduction of the heat between your fingers and the body, to creep towards a release. And that's what you're going to feel after 30 seconds.